everyone. Thank you so much first of all, for having me. I know John Blum had a great conversation with you yesterday, and just wanted to follow that up with some more CMS Innovation Center specific content and to help you understand a little bit about what we're doing. So we're going to have a slide presentation followed by some Q&A, and really look forward to the questions that you have. And I actually see Joy is here too, so she can help with any questions as well. So I am going to just jump in and start with, let me see, the CMS Innovation Center statute. And the reason I'm starting here is I'm sure many of you are familiar with our statute, but I wanted to highlight a few things. And I'm actually happy to share these slides with Mary Beth after this session for anyone who would like them. But essentially, the reason that I want to focus on our statutory mandate is that we are essentially required to test models that improve quality and are cost neutral, are quality neutral and reduce costs, or improve quality and reduce cost. And I think the reason this is important is that this is the criteria by which our models are considered for purposes of certification expansion. And what that means is if we test a model and we achieve that standard of certification expansion, it means that we can actually offer that model nationally. And the reason I wanted to focus on this a little bit and hit pause for a moment is I think you've probably heard Liz Fowler talk about this a little bit differently. And I think what she's really trying to help folks understand is that this is not the only way that we measure our success. So the CMS Innovation Center does scale models in different ways, and one of them is through the certification pathway. And so just to give you a flavor of sort of other ways that CMS Innovation Center models may be sort of scaled is, an example would be like the $35 insulin copay. That was something that the CMS Innovation Center tested, and then it was adopted by Congress as part of the IRA. So that was effectively scaled, but through a different pathway. Another example would be the ACO investment model and something like the Million Hearts model. Those were both incorporated through regulation. One was incorporated into the SSP program, and another was incorporated into the physician fee schedule. So that gives you a sense of how there are these alternative scaling pathways. That said, in terms of thinking about testing, we do really want to hold ourselves to the standard, the statutory standard of being cost neutral. So just wanted to flag that. I did want to also, and you'll see actually one of the bullets here actually relates to that previous conversation, but I did want to talk a little bit about an effort we undertook when the administration changed to really think about where is it that we're going with the Innovation Center. So I think, as you all know, we've been around for 10 years. We had launched many, many models or pilot tests. And we were at a point of saying, are we going to continue the next 10 years in the same way, or do we need to regroup? And I think the feeling was we need to reset and really think about where we wanted to get in the next 10 years versus testing models sort of on a one-off basis. And so I think what you will observe in our model pipeline, which I'll show you a little bit later, is that we're really focused on this accountable care goal. So moving to 100% of beneficiaries in accountable care by 2030. And then also focused on areas where there's really a critical gap that's not currently being filled. So that there would sort of be this ongoing primary care and really clinical care infrastructure that's working, and then below that or supporting that would be areas where we would test interventions where there's currently gaps. I did want to allude to just a couple things that we did find when we took a step back. We realized that there was not enough focus on health disparities or Medicare. You'll see that in some of our work. And you'll also see that there were, challenges in defining success. And I think that's something we've really worked on to help folks understand that we can scale in multiple ways. There isn't only this single pathway to scaling. I think other observations were, voluntary models can result in increased spending due to adverse selection. And that's something that we continue to work on, even though we do continue mostly to test our models on a voluntary basis. So in terms of our strategy, and this is a strategy that came out in 2021, and many of you are probably familiar with it, but there were 5 pillars to the strategy. And before jumping in and thinking about sort of the supporting pillars, we really defined our vision. And I think that that has really helped us think about what is it that we're working toward. So when we establish our criteria and our thinking around models, we really try to have that as our guide point of a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And I think we really want that to apply to all of our beneficiaries. In terms of the pillars, accountable care, what does that really mean? It really means we want beneficiaries to have a care relationship for somebody who has a longitudinal relationship with them and is responsible for quality and total cost of care. So that's really making sure that beneficiaries are linked to care providers. The second is embedding health equity. When we went back and looked at our performance over the first 10 years, we realized that there was not enough emphasis on health equity, and actually white and higher income beneficiaries were disproportionately included in our models. And as you can imagine, we wanted our models to be to serve a representative piece of the Medicare population, but also really to make sure that we were addressing gaps in care. And if we weren't able to do that through our current processes, we needed to rethink that. So one thing that we've done is, opposed to sort of tacking on health equity at the end, we've really integrated it into our entire process. So thinking about when we develop a model, are we really thinking about who can participate? When we put out the application, is it put out in such a way that will enable folks who may not have participated in a model before enough time to really think about how to complete it? I think, and then, as we go further, even implementation of the model, do some entities need more support? And in the end, the evaluation, where we think about potentially disparate impacts among populations. And one thing I want to note there is, historically, in many of our models, we did not include, for example, FQHCs, because federally qualified health centers are paid on a different payment system. And so it was hard for us to think about how do we operationalize our models and think through how to manage that complexity. And that is something we're doing a much better job with. And I think we've really gained a lot more traction in terms of recruiting those types of providers. And then in terms of supporting innovation, a lot of that is really helping our participants be more successful in models. Are there innovations that we can do to better support them? And Mary Beth and I were actually just talking about, we are starting to share a lot more data with our participants. And as an example, we are now sharing bundle payment data, like what do those episodes of care look like to ACOs, so they can see by clinician what those BPCI episodes, what those episodes of care look like for the beneficiaries participating in the ACO. And we hope to do a lot more of that in the future as we think more and implement more our specialty strategy. We also really want to think about affordability. A lot of the feedback we got as we did our strategy refresh and talked to a lot of different folks, including beneficiaries and advocates, was the need for greater affordability, particularly related to prescription drugs. And you'll see that we are pursuing a few different things related to that, but continue to really think about how is it that we can help beneficiaries gain access to affordable medications. And that continues to be a struggle for some beneficiaries. And then finally, partnering. And I think all of you in this room know that we really can't do this without partnership. And that is critical to our ability to be successful and to have people want to come into our models, to stay in our models, and to help us think about what the next generation should look like. So that is a key part of what we do. And we are talking to model participants and others every day. So I did want to pause and talk a little bit about our roadmap. And as I said, one of the key things that came out of those discussions as we revisited our strategy was the need for greater visibility about where we're going. So you'll see here the middle tranche is the model tranche, and then we have two supporting, we have the cross-model priorities and the external engagement. So I'll start with the models. I think you've seen many of these models listed here for 2024 that have been implemented. I'm actually going to talk about many of these models individually, just so you have a sense of what they are. But just to reflect back, if you see 2024, we talk about the models announced, new model launches, and then also, really thinking about sort of what's under development. 2025 to 2029, we try to continue to give a sense of sort of where we're going. We talked a little bit about specialty integration, and we do have a specialty strategy that maps out the different pieces of that strategy and how we'll implement it. Specifically, I think we talked a little bit about the data sharing piece. That is one of the first pieces we're implementing. And I think ultimately it moves to chronic condition bundles over a couple of years. So that's something that we're continuing to work on. We are continuing to think about partnership and different models with health plans and prescription drug plans. And we continue to focus on accountable care models. So as you know, we have an ACO model. We also consider our primary care models as accountable care models. External engagement, I said, is a big part of what we do. I think we have been doing increasingly more of that as we think through what should we look forward and think about where do we want to go? What are the types of things that are important to beneficiaries? I think it's been really instrumental, our discussions directly with beneficiaries about their experiences, both in the models and in the program. And then there are some cross-model priorities. I think some of you, if you participate in VBID, may have been at the forefront of some of the interoperability discussions, but really trying to push that forward as well, to really reflect on the fact that our participants are at very different levels of sophistication. So some still get Excel reports, but we are now supporting APIs and other mechanisms to share data. Having a little trouble. Okay. So this one, I think most of you are probably very familiar with, the value-based insurance design model. I think, this model really, the goal was to improve access to high quality, person-centered healthcare and address health-related social needs to help people better manage their health. And it allowed innovative targeting. And I think, as you know, some of the MA programs, the MA program evolved, and so did the VBID program over time. In 2024, there were 69 Medicare Advantage organizations participating, and it was available in 49 states, DC, and Puerto Rico. And there are 8.7 million enrollees projected to receive additional benefits through this model. And the additional benefits, as you know, are generally reduced cost sharing. And then there are the health-related social needs categories that the beneficiaries also are able to access. There are actually 12.4 million enrollees that are in participating plan benefit packages. And the thing that's unique about VBID is that benefits can be targeted by chronic health condition or by socioeconomic status. And this program has been running since 2017. As many of you have been following the evolution, it's changed a fair amount since then. But it currently is slated to end the end of December 2030. So this is a relatively longer model. If you were to ask what we hope to understand from this model, it's really to understand how that targeting can improve beneficiary quality and quality outcomes. And we expect that to also, through sort of a downstream impact, also impact utilization. I'm happy to answer any questions on that one when we get to Q&A. Okay, this one I wanted to focus on because I know many of you are health plan folks, and we really welcome partnership from plans on this model. So when we talked before about the CMS Innovation Center strategy and talked about areas where there are gaps, this is one that really sort of came about organically and came to us. So beneficiaries and caregivers noted that dementia care there was no coordination at all. You were essentially given a diagnosis and told to go home, and really started thinking about how is it that we develop a system to care for beneficiaries with dementia. I think another thing that was interesting about this is we were able to find organically centers throughout the country who were already doing this. And so what we were able to do is leverage a lot of their experience, what they had done to develop this model. And there are essentially three components of the model. And the first one is care coordination and management. So beneficiaries with dementia who are diagnosed with dementia would receive navigation and care management services. We will be giving the provider a care management fee monthly. There's no total cost of care obligation here. So it really is on top of another sort of, it can be on top of a model. So you could be in an ACO and also be getting guide. But I think the important thing here is really thinking about that person who's coordinating their benefits and really focused on the dementia care. There's also caregiver support and education. So there are systems to provide education, bring caregivers in, help them. In some cases, some of the existing programs have groups that meet, but really focus on what they can do to support the caregiver, because that's such a critical part of this disease. And then the final thing is respite services. And so again, this is really reflecting the fact that we are trying to make sure that sort of every piece of the care experience is covered through this model. And for the respite services, we are essentially funding respite for the caregiver, for the primary caregiver, for $2,500 per year. And the idea is that it'll allow them to take care of personal things that they need to take care of, and also really help them continue to care for their loved one in the community. You may wonder, reflecting on that initial metric I showed you, that sort of that statutory requirement that we have cost savings, you may wonder, well, how is this working? It's because we believe it will delay nursing home placement, that people will continue to be able to live in the community if they're provided with more support for dementia care. The reason I flagged this is we have actually sent out an HPMS memo on this, and we do want health plans who are interested to think about engaging with us. We have had some interest, but if you are interested, feel free to reach out and we can connect you with the team and you can understand the design of the model and how it's working. But we're really excited for more beneficiaries to be able to participate in this, and we think that would be a really positive addition of some of the Medicare Advantage folks as well as the fee-for-service. Another one that you may have heard of is the ACO REACH model. And that is a model really that is focused on, it's our third generation of ACO models. It really is increasingly sophisticated. So you do have folks who are moving more toward capitation. There are 132 ACOs currently operating, over 2 million aligned beneficiaries. So this is a relatively large program. You may ask, well, why do you have this and the shared savings program? This tests some things that the shared savings program does not. It allows for higher risk than is currently in the shared savings program. And we also have some flexibilities that are not included in the shared savings program. We work with our shared savings program colleagues very closely to think about how can the programs be complementary. And then if we test things and it works essentially like something like the advanced investment model, they can then put that in the shared savings model if that's something that they think would be supportive of the program. So again, this is running sort of in addition to the shared savings program, and collectively they have a fairly substantial number of Medicare fee-for-service beneficiaries. I wanted to pause for a minute on this one because this just got announced, so it's relatively new. This is actually being tested in the SSP program. So again, it's an ACO model, but it's focused on primary care capitation. And this has, there's been a lot of work thinking about primary care payment, how to increase primary care payment. And so this essentially tests a different primary care payment model structure within the SSP program. And this capitated model also allows for a one-time advanced shared savings payment to get folks started, and then monthly prospective primary care payments. So it's really a shift in how we think about paying for primary care providers. One thing I did want to note is you may be looking at this and thinking, what are low revenue ACOs? So there are two categories of ACOs in SSP, and the low revenue ACOs are the physician-led ACOs generally. They tend to be obviously smaller, and those are the folks that we are initially testing this on. And we're calling it the ACO PC Flex, but essentially it is much more flexibility around how we pay for primary care. The capitation is also what we call boosted, so it's higher than what the revenue that they would have gotten under fee-for-service. So turning back to gaps, and this is another one if anyone is interested in participating, it's actually a kind of an interesting model in that I think it very directly addresses a gap. So as we start to think about behavioral health, which we kept hearing about from our providers, and so many issues related to behavioral health, we started to really look at the landscape and realize there were so many different programs being offered. And we sort of asked ourselves, is there anything that's missing? Is there any specific population that's not being addressed? And what we realized is that there was a group of beneficiaries who were moderately to severely mentally ill who used behavioral health clinics in the community, but were not linked back to physical health care. And so they were getting services for their mental health diagnosis in the community, but they weren't connected back to the physical healthcare system in any way. So the goal of this model is actually what we're calling reverse integration, which is trying to link them with physical care and in some cases trying to co-locate physical care with that behavioral health provider. This is going to be done in collaboration with states. The application period just closed. We would consider a maximum of 8 states, but not more. And again, the idea is that it would be Medicare and Medicaid joining together to really address this need in the community. And once we understand, does this work, then we could scale it potentially to other states, but also think about how to incorporate it more formally in the different programs. In terms of how we do this, there will be an alternative payment model. There's also an agreement with the state that enables them to build infrastructure to be able to test this. Okay, I know this is a lot of models, but this is another one that I would term as sort of a gap model, really filling a gap in terms of maternal health care, another very high priority. This one will have more states, has a similar application period. It's a little bit later, so it hasn't closed yet, but it will be larger, and we will partner with about 15 states on this one. So 15 states will be able to participate, and again, it's really focused on what is the piece of that care continuum that is not currently well addressed, and focusing on integrating much more community health workers and doulas and other professionals really into that so that there's more whole person care. I think there's a lot of excitement about this, and particularly on the Medicaid side, a lot of opportunity for also some, which sounds really dry, but some even information technology investments that will allow them to do things like link the mom and the baby, which will have, I think, much better impacts in terms of thinking about the overall outcomes. This is one that you may have heard a little bit about, and it is called, again, it's one that's very targeted, is the cell and gene therapy access model. This is being done in partnership with states. It's in process now. Essentially, the reason we ended up doing this was the gene therapies are extraordinarily expensive. And states are thinking about how do we pay for these. And so, sickle cell disease is a really terrible, painful disease. And there's now this gene therapy, actually 2 companies that are offering gene therapy for those folks. And the goal here is to really think about how do we develop a model that allows CMS to do a lot of the work in thinking about structuring an outcomes-based agreement. A lot of that is thinking about what outcomes will we measure, where will we find the data, who will actually track the data, and also thinking about are there discounts also that CMS can negotiate based on aggregating states. So we are still in the process of this. I think we are enthusiastic, but again, this is very, very new, and we want to do this really in partnership. This is all voluntary. So the manufacturers are voluntarily participating, as are the states, to see if we can come to an agreement on how to do this. I think there's a real commitment from both that they want to make sure that folks have access to these therapies. So we are continuing to think through how to work with them on that. There are some things that are can be included as part of a model, one of which is fertility preservation. So that would be for folks who join in the model, that is something that we are allowed to offer under our waiver authority that can't be offered under the regular program. So that was a very quick rundown of all of our models. I know it's a little bit overwhelming. I feel like there's actually one we didn't include, which is a state-based sort of whole state innovation. But just wanted to encourage you to continue to follow us. And again, we are always happy to meet with folks and get input. That really is where we get so many of our model ideas, and really welcome the collaboration and partnership with the Alliance, but also others in thinking about how to implement these and make them successful. So again, really appreciate your time. I can open it now for Q&As.
Thank you. Philo Hall, Epstein, Becker, and Green. Thinking about the new team model rolling out soon, replacing CJR and BPCIA. The joint CMS OIG fraud and abuse waivers tend to come with each model sometime after the first plan year gets launched. Is there a time frame in which, if there are going to be such waivers for the team model, stakeholders should expect to look for those waivers to be coming out?
Yeah, that's a great question. That's a mandatory model. So, I think there was initial rulemaking, and there's going to be probably subsequent rulemaking. But I think you should see those earlier rather than later. They are starting to do participant educational calls, even I think as early as the next couple months. So I think in the process of that, they will try to be clear about which waivers will be available. And that was actually a model we didn't talk about, which is a mandatory episode model.
Hi, Caitlin Redpath with BMA here. VBID, we know that's been extended to 2030, as you mentioned, and I also know CMMI often integrates learnings from other models as they think about the next iterations of these things, including VBID. Can you share some of those lessons learned and just observations, perhaps from other models, as you think about next stages for VBID?
Yeah, that's a great question. I think, so a lot of what we've, like anything, when we test a model, it's not in a static environment. So when we test, for example, let's say even an episode model that was being reflected on before, where you're testing joints. So we're testing this hospital payment for joints and then some period after. And then suddenly our partners on the other side tell us, like, we really need to start doing this on an outpatient basis, right? And so you have to change and evolve constantly, I think. VBID has been great in terms of us learning a lot more about how beneficiaries are using supplemental benefits and how to collect information on that. And I think that will really help the agency in general understand much more about that population. In terms of thinking about how we conceptualize, like, what changes need to be made in a model, we really think about, where are things going? What is sort of the end goal? What is it that we want to get to? And I think you were raising that really well with ACO REACH, sort of like, where is the end point and how do we get there? And if a model is unlikely to be certified or expanded, then what is it that we do? One caveat I will make is that you probably saw this with ACO REACH, is that when we do get an evaluation report that shows that we are likely losing money, the statute actually asks us to modify or terminate. So generally, you will see us, like, working to really think about, how can we modify this model? What is it that's not working? We did make changes in ACO REACH in response to the evaluation report, just to try to really improve our performance in that model. Any other questions? Well, I will definitely share the slides. And if you all think of anything, definitely feel free to reach out. But appreciate the time and always appreciate the engagement from this great group.